So I presented a poster with some data from the Myeloma XI clinical trial. Myeloma XI was a really large national clinical trial run across the UK, and I was looking particularly at the patients within the trial who'd had an effective quadruplet induction combination of Carfilzomib, Lenalidomide, Cyclophosphamide and Dexamethasone. These patients then went on to have autologous stem cell transplant and were then randomised between having lenalidomide maintenance or observation. I was particularly interested in focusing on patients who relapsed early following this combination. So what we see with the quadruplet is that most patients respond and have very deep responses, but there are unfortunately a subset of patients who still relapse early within a year of their transplant. And what I was interested in looking at was how many of those patients we could potentially have predicted may have relapsed early based on their genetic status as assessed by 414 translocation, 1416 translocation, 1420, deletion 17 or gain of 1q. And what was interesting is that although some of the patients who relapsed early, and in fact the majority, did have high-risk disease genetically, there are also some patients who did not have those markers. And so it's interesting to think about the phenotypic high risk, so those patients who relapse early despite having potentially standard risk genetic disease. We know that some of those patients could potentially be picked up if we used other technologies, so maybe gene expression profiling on baseline bone marrow samples, but potentially there is still a subgroup of patients who have early relapse disease, relapsing within a year of their transplant. And what's really important is that when we looked at their subsequent outcomes, so their progression-free survival on their second line of therapy, it still appears that they have inferior outcomes to patients who didn't have early relapse with their first line of therapy. So we really need to think about how we could potentially change that first relapse therapy to try and minimize the ongoing effect of the initial early relapse.